Yes, good afternoon, everybody, and for all our European guests, and good day for the international participants from all over the world. I'm going to start this lunch webinar of the European Forum for Primary Care. We have these kind of webinars very often. So take your sandwich, switch your microphone off, and watch and appreciate what our Slovenian colleagues will present for us today. I'm Diederik Arendonk. I'm the coordinator, already almost 15 years, of the European Forum for Primary Care, trying to get you all together on this precious subject of primary care improvement and enhancement. We have our guests, as I said, from Slovenia. They have prepared a real great video of their practice and their activities during the last 3 months in the COVID-19 crisis. And I'm happy to have 3 of the key persons in the Ljubljana Health Centre, but also in this video present to give some further explanations on what has happened the last 3 months, and also what you can see in the video. We have present Dr. Tonka Popla-Susic. I think most of you will know her, 5-star doctor of Wonka Europe a couple of years ago, and very, very active in practice, academic and policy making. And her 2 colleagues are Teja Stehnje Injatovic and Spela Tevcic. They will present themselves after the video with some extra information on the Ljubljana Health Centre. So I want to continue with saying what is the program. We will start with the video of 60 minutes. Then we have these short presentations, and after that we have some discussion on the basis of questions, and we try to finish at 1:30 European time. Questions, indeed. We ask you to make questions and put remarks in the chat box, which you can find in the go-to environment. And there's one additional request. Please note the timing of the video, where it is located, the time slot, so we can maybe show it again if you have your question raised. Don't wait until the end of the video to raise your questions. Just go ahead throughout the video and also during the presentations, so we can already have a view on these questions and remarks from your side. We keep the cameras closed of all the participants, and also the microphones muted to increase the quality of our session. Having said this, I will now start the video, sharing my screen, and hope to have a good view on 60 minutes video. Have fun.
Primary health care to the population of the capital, Ljubljana, and beyond. We provide care to close to 500,000 of registered patients, contributing to more than 2.8 million visits a year. At the entrances to community health centers, triage areas were established already in February. Here, healthcare professionals direct patients and make sure there are appropriate numbers of service users who can be in the unit at the same time. Despite this, patient 0 emerged on March 4, 2020. Regardless of all the procedures, he managed to enter the waiting room area, and it was found later that he tested positive for the new coronavirus.
Ne zaupaš najprej na začetku temu izvidu, da je to dejansko res, da je to tisto primerno. Pa začneš razmišljati v bistvu, kaj vse si ti naredil takrat, ko si pristopil do pacienta, si sploh imel masko, si razkužil roke, koliko ljudi je bilo takrat v tisti čakalnici, koliko zaposlenih je bilo zaradi tega izpostavljenih, pač en cel kup skrbi se pa sproši.
With the outbreak of COVID-19 in Slovenia, we had to address a comprehensive reorganization of our existing operations. Even before the first case was reported, Slovenia monitored the situation in China and in the neighboring Italy. We tested in practice our contingency plan for infectious disease pandemics. As the infection spread in our immediate neighborhood, we immediately set up the crisis headquarters consisting of the extended management, representatives from infection control related to healthcare, a nurse representative, and PR services, which meets at least twice a week.
When organizing work during the epidemic, it is crucial from a professional point of view to ensure rational use of personal protective equipment, rational allocation of human resources, good provision of information to employees in terms of rapid transmission of information, coordinated action of department heads with management, and clear management guidance to keep employees and patients feel safe despite the uncertainty of the situation during the epidemic.
The professional management of the institution and of the crisis headquarters translate into working 24/7. It means that one is devoid of one's own wishes and lacks leisure time. Also, one cannot devote time to all the little details, making treatment easier for patients and employees. The permanent teams of coordinators were appointed. They are tasked with work organization by areas. It is essential that the team is permanent, and a 24-hour call center was set up as well. The call center was designed to raise awareness about proper preventive measures and to ensure continuous availability for the population in case they have doubts or questions. Appropriate personal protective equipment provides a basis for the safe work of our employees.
Making sure that enough personal safety equipment is available during times of epidemic is a very big challenge. The Commission for Prevention and Control of Healthcare-Associated Infections focused its activities on the immediate education of employees, the provision of personal protective equipment, isolation facilities, and the preparation of entry points for testing and supporting documents such as working instructions and reminders.
At the level of Slovenia, taking swabs for the new coronavirus is concentrated to 16 entry points. The entry point of the Ljubljana Community Health Centre, as the biggest entry point, covers almost 1/4 of the population in the country. Patients cannot come to the entry point for taking swabs unannounced, but are referred there by their general practitioner or the on-call doctor following telephone triage. The so-called drive-in system was introduced so as to accelerate taking swab samples, thereby greatly improving patient flows and the number of swabs taken.
Work at the entry point has been perfectly organized from the very start. A high level of personal protective equipment is being provided. Working in all weather conditions is a particular challenge. However, due to the team's great dedication, work ran smoothly through all the day.
Our units were separated into infectious and non-infectious part. Patients at risk who do not have COVID-19 suspected symptoms are scheduled for an appointment taking place in the centralized clinic for non-infectious patients.
We have pediatrics offices for well-child visits with separate entrance so that infective children don't mix with the healthy ones.
A day before examination, the nurse calls the patients and checks if everyone at home is healthy. The child is scheduled for an appointment accompanied by only one parent, provided that all family members are healthy. Work is organized in such a way that the patients do not meet while the rooms are duly cleaned and ventilated. A patient who believes that she has to be examined first calls the clinic of his or her GP. If the doctor, after conducting telephone triage, estimates that the examination is needed, the patient gets an appointment. Upon entering the community health center, the patient receives a surgical mask in the triage area and disinfects hands. The persons without the appointment cannot enter the community health center. Healthcare professionals have a demanding task in this period. Most treatments are delivered with telemedicine. Patients send photos of medical condition symptoms and via the phone present medical history and measurements. Phone replies do not allow for touching and seeing the patients, who often express through body language what cannot be uttered in words. Hence, the doctor always doubts if the right decision was made.
Professional judgment is much more difficult under these circumstances. We want to protect healthy patients from being infected with new coronavirus. That is why we choose long-distance treatment as often as possible, even if it means prescribing antibiotic without clinical examination.
We needed another strategy. We needed to organize common COVID unit, which first started operating on 16th of March. Doing this, we had two goals in mind. We wanted to make sure that infected patients don't mix with healthy ones, and we wanted to optimize the use of personal protective equipment.
We set up the entry point for the examination and treatment of patients with suspected coronavirus for the patients coming from the central Slovenia region, which in total means 575,400 patients from the Ljubljana Community Health Centre and 7 other community health centres, as well as all concession holders in these regions. The COVID screening clinic separately treats adults and children. This clinic is not designed for examinations of all acutely ill patients, but only for those where the GP estimated that monitoring via the phone was no longer safe. Patients receive a scheduled appointment over the phone. Once they are in front of the clinic, they ring the bell at the entrance and wait for the nurse to open. At the entrance of the community health center, they receive a mask, then enter the clinic and give the health insurance card to the nurse. Upon the examination in the COVID clinic, the physician determines the patient's clinical condition, runs different investigations and laboratory diagnostics. If blood collection is required, it is performed by an adequately protected lab worker. Following the examination of the patient, the physician estimates whether referral to a hospital is needed or if the patient can stay at home, and telemedicine is performed. The work organization protocol has been drafted for activities in the COVID clinic. Employees also follow instructions with regard to dressing and undressing of personal protective equipment. After working in the COVID screening clinic, it is very difficult to go home to one's family, young children, grandparents, while knowing that there is at least a theoretical chance we could be infected. As for general continuous emergency medical care in the Ljubljana Community Health Centre, we immediately started adapting our work organization to the epidemiological situation, both at the emergency unit as well as in the field. A swab is taken from all the patients with suspected COVID-19 before entering the emergency unit. We also had to adapt the provision of emergency medical care in the field. The emergency medicine team puts on personal protective equipment already before entering the ambulance or before departing for intervention.
For the time of the epidemic, an additional team has been set up at the General Emergency Department, CHC Ljubljana, dedicated to home visits of immobile patients with suspected or confirmed COVID infection. The healthcare professional team examines such a patient and provides them healthcare at their home.
House calls are centralized for all patients in need of such care. If necessary, when examining the patient at home, a swab is taken as well. The majority of patients stay in home care. In the case of a relevant indication, such as, for example, a chronic wound, decubitus, patients at home are visited by community nurses who enter people's homes in the period when social contacts are prohibited. Hence, the patients at home are even more vulnerable and exposed. Particular attention should be paid to the most vulnerable population in social security institutions.
Several doctors' offices of the Community Health Centre Ljubljana are operating within retirement homes. The first cases of COVID also appeared in the retirement home Bukalci. This is where we organized the department for COVID-positive residents.
In case of the infection, care recipients are divided into 3 separate zones. Infectious, a gray zone occupied by residents with suspected COVID-19, and non-infectious, Due to the shortage of healthcare professionals following COVID-19 infection, teams from the hospital level have also been involved in the care of COVID-19 residents. An individual treatment plan is prepared for every care recipient. We centralized all the activities, reduced the number of direct contacts with patients, separated and centralized the treatment of infectious and non-infectious patients in need of medical examination. In this way, the spread of the infectious disease, both among the general population as well as among healthcare professionals, is limited to the maximum. In our premises, the entry point for emergency dental medical treatment of the wider Ljubljana region, which is one of 7 at the national level and covers the largest share of the population, came into operation. Patients are scheduled for an appointment by their chosen dentist, following telephone triage via the call center. Clinics have been refurbished according to work needs and a highly infectious environment. Throughout the work process, the areas are protected by way of compresses. All the instruments are individually packed and sterilized. All devices and instruments, which are not absolutely necessary, were removed from clinics.
The organization of an entry point is a living system which requires constant adaptation to the needs of patients, healthcare professionals, as well as equipment. For this reason, we decided for the organizers to be present at all times.
During difficult and demanding times, such as this epidemic, appropriate attention has to be devoted to the employees when they encounter fear, helplessness, and different circumstances. It is therefore important that our associates are equipped with relevant skills and tools.
Rada bi pa starše videla, ki jih nisem videla že cel mesec, ki oba dva sta starejša, sta bolna, nikaj ne potrebujem morja, potrebujem ljudi, do katerih ne morem zdaj.
Čakaš, da boš ali zbolel, pač nekak tiste strah te skozi malo gnjavi. Moja mama ni v redu in imam en tak občutek, občutek krivde, da bi ni tam zraven.
Vsekakor bi z veseljem šla domov. Taka je situacija.
The Primary Healthcare Research and Development Institute within the Simulation Center organized training by means of simulations in relation to the correct taking of swab samples, efficient communication during the epidemiological situation with users and employees, and the demonstration of correct use of protective equipment. The changed operation of primary healthcare impacts the provision of care to patients and the well-being of healthcare professionals.
Education using simulations in healthcare is very important, especially when talking about intervention that we do not do every day. And we don't have epidemic every day, we don't take swabs every day, and we don't have crisis communication every day. These are interventions that simulations in healthcare make sure we stay competent in, and it makes our practice more safe.
We monitor our services, record our own actions and track the data that will help us analyze what could be done in a different and better way in similar situations in the future.
We plan to examine the views of professionals with regard to changes in work organization and the operation of family medicine outpatient clinics. We are going to compare the situation before, during, and after the epidemic, elaborate the model of future measures, exchange the results, and also compare them internationally.
Research provides insight into a changed functioning of primary health care during the epidemic. This enables us to design a model that provides quality patient care in similar situations in the future.
Good cooperation with the local community is of the utmost importance in the current situation. Hence, our sincere gratitude goes to all the people as they recognize the seriousness of the epidemiological situation. They cooperate with us and in the process demonstrate different forms of help to make our work easier. In tackling the demanding epidemiological situation, we have been greatly assisted by the civil protection of the city municipality of Ljubljana. The city municipality of Ljubljana facilitates our work process by providing us additional space and arranging free parking in the vicinity of the community health center, thereby improving the availability of healthcare and the treatment at the entry point.
Only collaboration is the key to success, and we have succeeded.
In this documentary film, we look back for the future. Surely, a similar story awaits us, and then it will be easier. The epidemiological situation demanded new organizational measures and many adjustments, and at the same time, it brought us closer together.
Running such an institution means being constantly available to all employees, reporters, and decision makers. This brings changes to our daily routines, changes to our lives. But from the complexity of this situation, one must take out those elements which can ease our work for the future.
Okay, this was the video, and I think it was impressive and comprehensive, the video itself, but also with the Community Health Centre trying to be as comprehensive as possible. What I would like to propose is that I give the floor to Tonka and her colleagues, and that they can say a few more words about how the video was shot and what has happened in these 3 months, what kind of crisis they additionally want to share with you, and then you can ask questions. I don't see any questions up till now in the chat box, so please come up with your questions, because I think it makes our discussion more relevant. Tonka, can I give you the floor?
Yes, thank you. I would like to introduce myself. Firstly, my name is Tonka Susic. I'm the primary health care development center, Ljubljana. My task during that period was to maintain an overview of the current situation in accordance with the epidemic situation in relation to the patients management and the organization of healthcare, which was directed by professional bodies or institutions in Slovenia. We also started immediately to collect data, qualitative and quantitative, for analysis and scientific purposes, because a similar situation should be provided with fewer obstacles in the future. I have to say that we had only one infected employee among 1,600 employees. And this only person got infected outside of the community health center at the party. And we successfully limited this infected patient from the other employees, and it was a success for us also. With me is Špela Teužić. She's family physician, and I myself, I'm also family physician working for 30 years as a GPs. But Špela is a young family physician, and she met the first COVID patient, was involved in other areas, so I would like to ask her to introduce herself, and after that our medical director Teja was practically involved 24 hours a day, 7 days in week in this organization process, and she will start her a short speech after Špela.
Thank you, Tonka. So my name is Špila Teužić. As Tonka said, I'm a family medicine practitioner here in Ljubljana. I saw the first patient that appeared in Ljubljana, in Slovenia. I worked for a shorter period of time in COVID clinics, and for the past 2 months, I've been working in retirement home Bokalci. Bokalci is one of 11 retirement homes under the governance of the healthcare center Ljubljana, and is the only home that had COVID positive patients. Another retirement home, Huriul, also had a couple of positive patients that's in this greater Ljubljana area. So we take care here in Bokalci, we take care of around 380 residents, and we had 17 cases, 4 which unfortunately died. But we were able to work with regional coordinator Dr. White, who was appointed by Ministry of Health to basically coordinate the care for COVID positive patients. A couple of specialists of intensive care came to our home and met with us, and we talked about how to best treat those patients. We also set up 2 zones in the retirement home, a red zone for COVID positive patients and a gray zone. So everyone that had certain respiratory problems or high fever was transported to the gray zone and then tested and was awaiting the results there. So I think this is it, and I would like to ask Thea to go along.
Hello, I am Thea Stignejnjatović. I'm the Medical Director of Community Health Centre Ljubljana, as Tonka already presented. As shown in the video, our Community Health Centre Ljubljana is the biggest in our country. We cover a population of Ljubljana and beyond, that's approximately 400,000 patients. But during the epidemic, which started the 13th of March, we actually were one of the 16 entry points for treatment and testing of suspected COVID patients. But our entry point, the Community Health Centre Ljubljana entry point, is actually the biggest in our country, because we cover more than 570,000 inhabitants of central Slovenia region. So that's a quarter of the population of Slovenia. We in January and February, we were closely monitoring the outbreak of COVID-19 in China, and during that time we were ordering personal protective equipment. We were informing our employees how to properly use personal protective equipment. But when the outbreak of COVID-19 in February started in neighboring Italy, we immediately set up the crisis headquarters that is consisting of the extended management, then a representative of nurses and representative from infection control related to healthcare, and a PR service as well. And this crisis headquarters met at least twice a week during the whole crisis in Slovenia. And we immediately set up our plan for infection disease pandemics that we have in our community health center, that we established it even before the epidemic was started in Slovenia. So we established triage areas and entrances to our units. And later on, we realized that the problem is in Italy is the lack of physicians and nurses, because they are being infected or they are put out of process because they had a contact with a COVID positive patient. And we realized that we need to provide a sustainable health system on the primary level in order to give medical care to the patients in need, the ones with COVID and the ones that are elderly, acutely ill or chronic patients. So we all our medical staff was put in 2 weeks rotation in order to keep our medical, so the physicians and nurses, healthy. And in this way, we rationally distributed healthcare workers and also rationally distributed the personal protective equipment that we didn't have enough, especially in the first months of the epidemic. Of course, in order to prevent spreading of the infection, we lowered the number of personal contacts among patients and healthcare workers. And we did it with centralization of all of our activities. That means in family medicine, in pediatrics, in dentistry, in ophthalmology, and also in radiology department as well. And we separated and centralized the treatment of infective and non-infective patients that need medical examination. And as one of the 16 entry points, we had a centralized COVID clinic that we still have, so far we still have, that all the patients who were suspected or actually confirmed COVID positive were appointed to this clinic. In family medicine and in pediatrics clinics, we established practices that were only administrative. And in those, the physicians who were more vulnerable to the infection were working. Young doctors were working in the clinics with patient contacts, or the non-infectious patients, or the patients with COVID. And this is the way that we, as Tonka said, managed that only one of our employees got infected during the whole crisis that lasted almost 3 months. That's everything from me.
Okay, that's an additional information which is valid. Thank you, all three of you. I see some questions, and I think you answered already the first one of Anthony. When did the epidemic start in Slovenia? But you also said already something about a second question. How long did it take to organize this strategy and pathway? And I think the strength of your story is that you already started before the start of the epidemic. But then still, how long did it take to get all these things ready, which you were presenting?
Well, actually, we didn't have much time. We were one of the 16 points, and we already, before being assigned as one of the 16 entry points, we already centralized the swab testing in one of our units. So afterwards, we just spread this organization and involve also the physicians and nurses that were coming from other community health centers, and also the physicians and nurses coming from the clinics of concessionary clinics as well. So we didn't have much time. We actually did everything in 2 days. But afterwards, we wrote protocols, and those protocols were continuously updated because of the information that was changing all the time about knowing new things about new coronavirus and COVID-19.
You said something about the concession holders, and you ended the video in collaboration is key. I think that's interesting. So you could collaborate with those concession holders without limitations, the same as you did with the municipality, which provided maybe from the start extra parking lot. Was that the case, that there was so much collaboration between all those different partners from the start, or did you also experience problems in that collaboration?
I actually have to thank all of our co-workers, because they immediately realized that the situation was serious, and we didn't have much problem with collaborating with other physicians and nurses that are not employed in our community health service. They were all very cooperative. And also the municipality, as mentioned, we started with containers where we started taking the swabs. But afterwards, in 2 weeks, we realized that it's not longer possible to do it this way, because the number of tests was exponentially increasing. So we, in a weekend, we managed to make a drive-in system that we still have.
Okay. What struck me as well, and then I go also to the question of Mehmet, but what struck me as well in the video is that it seems like you did have a continuing a normal patient flow of also non-COVID-19 patients, that there was not suddenly no any heart problems and no other COPD or whatever. Is that correct? And how, can you explain, because in many countries, including Holland, we faced in primary care, doctors were sitting doing nothing at a certain moment.
So as I mentioned before, we were in 2 weeks rotation, but we centralized the COVID patients in one of our clinics. But all other units were working with non-COVID patients. So there was a lot of work, a lot of telemedicine, but also the patients who needed examination were given an appointment in a centralized non-COVID clinics. But maybe Spela, which was actually the frontline doctor, will explain much better how these clinics were working during the epidemic.
Yeah, and then in particularly if you indeed, Spela, did you have the idea that normal patients were still coming, that they were not afraid or whatever blocked for coming to your healthcare center?
There were several patients that wanted an appointment and came to our units, but we had a triage set up in front of each unit that ask certain questions, and then the people who were suspected of having COVID, or even other people, were then told to call their family physician and just to see what can be done.
And maybe it's not so it's very important that we included the PR service in our actions. It means that all announcement, news, and what is going on is published on daily, weekly, or I don't know how often level on our webpage, in media, on the radio, and all people are asking not to going to physician. Do call them, do contact them, do discuss with them their problem. And it was very, very successful. Patients realized that the situation is seriously, and they realized that we as a doctor work with infected patients and that we have a family at our home. So they suggested us to hire their flats to live there for 14 days, that this period can turn out as infected or not infected. And in fact, on daily basis, we got the mails with thank you, our physician, to take care, to be there. Yeah. And this collaboration ran really good with open communication, including media, including our web page, because we realized that without patient we can't go out of this situation.
Yeah, okay, thanks. Mehmet, can you open your microphone and explain a little bit more your question? And if anybody else has a question, please make a note in the chat box that you want to make a question, then I give you the floor. Mehmet.
Hi, thank you very much for this excellent presentation. I was just wondering, I mean, this isolation also makes the connect difference difficult between the people and also the healthcare workers and the community. So, I mean, was there any problems regarding to be disconnected from the community? And especially, I know that COPC approach is being, I mean, practiced in Ljubljana for a long time. So how could you continue COPC approaches? I mean, while there are a lot of, I mean, telemedicine and other kind of distance consultancy methods. And also when everybody is isolated at home. That was just
yeah. The CPC Mehmet is referring to community-oriented primary care, but I think you understood. Yeah.
Yes. Yes, actually, during epidemics, the point is the community, not only the patient, so the personalized medicine, but more community dedicated one. Yes, we saw that isolation is a problem, but we established very good connection by phone or email, and our physicians, nurses, also our psychologists were available on phone and on Skype or on email to talk to the patients. We established a phone for psychological support that was 12 hours per day available for all the patients who needed some psychological support. We tried to be available, and the patients, that's the reason they felt secure, and they didn't feel the need to go to the physician, to go to the emergency department. I must say that they phoned first, and they did listen to the instructions that the government was giving, that our National Institute for Public Health was given on media, and all the news that were published in our website. We had a great collaboration with the community.
Yeah, thanks. What struck
and sometimes
go ahead, Tonka.
Sometimes also home care nurse was sent to the patient's home when we realized that these media are not sufficient for treating patients, and also physicians visited their patient at home. It was really rarely, but it happened.
Tonka, in addition to that, when home care nurses and also in the situation of nursing homes approached patients, and also not non-COVID-19 patients, were they fully protected? Were they wearing mouth masks and these kind of things always? Yeah, I see.
Yes, they do have. Everybody have this equipment.
Yeah. I don't know what other people think, but have you seen the statistics of all this? And of course, there are a lot of other aspects important in all these statistics. But it's clear that Slovenia, with only 1,500 infections and a bit more than 100 deaths on a population of 2 million people, scores very well. If I compare that with our Dutch situation, it's dramatic. And what I have seen, and I don't know if others will want to react from other countries, in our country, and it's now coming more and more in the news, that the biggest problem was in the nursing homes and with the elderly living at home, being approached with personnel not well protected. And this is still going on. It's unbelievable. And I'm happy to see that you tackled this also from a primary care perspective, that you were involved from your primary care position in providing good, appropriate care in nursing homes. Is there anybody else who wants to react from his or her country where it was good or bad in that respect? You can open up your microphone if you want to say something. Maybe Rich Roberts from the United States. How things are going on in nursing homes and home care for normal patients at the moment?
Hi, are you able to hear me all right?
Yes, you go ahead.
Well, with a country of 330 million, it's a little difficult to generalize. There are some parts of the U.S. that have kept things very well under control. The more densely populated areas, such as New York City in particular, was really a catastrophe in that the critically ill people just overwhelmed the public hospitals in New York City. And so the call went out, and about 80,000 of us from around the United States volunteered to help. And some of us got called to do that, and others did not. I think the thing I would like to first compliment the Slovenians on was coordinating and cooperating, as well as it sounds like you did, between public health, primary care, and your community, the people that you serve. You know, that may be perhaps a little more straightforward, or perhaps a little bit easier to do with 2 million people, and it's kind of hard to do across very large countries like Russia or very densely populated places. But I think that really, to me, represents the best way to come at this, is to bring all the key people to the table, including the patients and the community leaders. The other thing I think we've learned in the United States is that there's an old Sicilian saying that the fish rots from the head down. And when your leadership at the top appears unhelpful or confused about what's going on, it really sets things off in a bad way, because there are going to be many people in your population that are going to resist any sensible public health measures, and those very small number of voices sound much louder than they should. So again, my compliments to the Slovenians. I think it's a good model for all of us. I would frankly like to see primary care doctors, family doctors, figuring out better ways to stay connected to patients all the way through the health system, including the most critically ill, because whether it's an older person that's very frightened in a nursing home, or somebody in an intensive care unit on a ventilator where they, or at least their family, are very nervous about whether they're going to survive or not, those are exactly the times you want the family doctors involved. Don't just wash your hands because you say, well, that's for the intensive medicine doctor to take care of. So thanks for the chance to comment.
Thank you, Rich, and happy to hear that you also emphasize the collaboration, the connection, the integration between public health and primary care, which we have seen in the video so much, which is, I think, key in the approach of this crisis. Where we in the Netherlands, maybe Jean Murus can say a few words about that as well. But I think in Holland, this match between public health and individual health and all the isolation measures, which make life almost dramatic, is not the best example. And maybe Veerle from Belgium can also something about the situation there. Jean, are you able to say something? Open your microphone.
Yes, I hope you can all understand me or hear me.
Yeah, correct. Go ahead.
Okay. So I think in the Netherlands we have the lucky plans. We had this Q virus fever epidemic a few years ago, and we had our plans ready when SARS came in. So all our individual, and that relates also to the question that Mehmet is asking. We are 10,000 GPs and in 5,000 or 6,000 practices, but we had all had plans to scale up. So we had Corona hotels where we did rehab, and we had the same tents as you had outside of buildings to screen. So I think it's essential for primary care to have their emergency plans, but especially the scale up plans in place. So you don't have to make it straight from scratch. And the other thing is that we now see that in my practice, I have about 3,000 patients. We have now 10 patients who were only seen by the primary care doctor. They mostly were 2 weeks with fever at home and a kind of pneumonia or interstitial lung disease picture. There are young people, elderly people. There are people who do sports. They bicycled, as we do in Holland, 200 kilometers a day. But now, if they can do something for 5 minutes, it's max. So I think we're heading for a real big post-COVID fatigue syndrome and dyspnea syndrome in our country. So that is what I think is going to happen. And then the primary care, a multidisciplinary primary care team with a nurse practitioner on psychosocial and psychological problems, but also the physiotherapist is already being seen as of much added value to help these patients. So, and it's a very complicated situation because some of these patients, some of these 10 patients I have, they are now corona negative, but they still are not, well, they cannot be reactivated. They have complaints for months, but they do not, cannot go back to work. And then you get the doctor from the companies, how do you call it, occupational physician, calling me, why does this guy or woman does not work? So there's a lot of trouble, and I think you're right, Diederik, that the connection between public health and primary care, also in this developed country, is not developed enough to answer all these questions. Thank you very much for asking me.
Thank you, Jean. Yeah, that adds, I think. I see a nice question. I'm coming back to Mehmet's question as well, but from Catherine Dagneux from Belgium. She suggested that in Belgium, the large influx of people coming from North Italy, Lombardia, which is nearer to Slovenia than to Belgium, I believe, that causes the big epidemic. And they were not tested. Have you had in Slovenia the possibility to test everyone with symptoms from the beginning? So, for example, those coming from Lombardia, being on winter holidays and flying back or riding back to Slovenia. Thea.
Yes. So in February, when we started the first testing, we weren't centralized yet, and every physician had the possibility to test, to take a smear of a patient who came from northern Italy and had symptoms of COVID-19. But the epidemic was started at 13th of March, and at this time we were instructed that patients who had mild disease did not to be tested, they just have to stay at home. But after a week, approximately a week later, the government and the Public Institute of National Health decided that all the patients with mild disease who are elderly or who have other chronic illnesses have to be tested as well. So all the patients that that actually would need a hospitalization in the future, we had to test them all. And in April, so after a month, we had enough tests in our country. So the decision was that all the patients, it doesn't matter age, but only with symptoms of COVID-19 have to be tested.
And they were.
So we didn't have a lot of problem with tests.
No,
we were quite lucky with it.
And then in addition to what Anthony is asking, was that also available on primary care level, this testing, or was it only mainly located at hospital level?
No, it was actually on the primary level. Every GP had the possibility to do the test according to the definition of the case that the National Institute of Public Health published. So even the entry points in Slovenia, the 16 entry points for testing were centralized on primary care level. So the community health centers, the bigger ones, were the ones who had to organize the testing, not the hospitals.
Yeah.
And our, as said, our was the biggest. We have to cover a quarter of all the population in Slovenia.
Yeah, yeah. Okay. Well, Mehmet is also asking, and I would prefer to ask that question to our Belgian colleagues, but you might also have an answer. I just wonder, will it be more difficult to have a comprehensive approach in a situation where primary care is offered only by independent clinics or individual GPs? So, you said already that these concession holders were joining you. So apparently you had already this collaboration established with those individual working GPs, is it?
Yes, the concession holders that are in the area of Community Health Centre Ljubljana, they already are involved in the emergency department that we have to organize as a Community Health Centre Ljubljana. But later on, as the area that we had to cover was bigger than before, other concession holders were also involved, and other community health center employees as well. But it was something that the government was deciding, and we, as the management, were emailing the other or phoning the other management of other community health service or all the concession holders that we need their involvement. And we just made the list of the dates and the dates that they have to fulfill. And we didn't have much problem doing it.
But they were obligatory to do that, or on a voluntary basis?
No, it's obligatory because we have the law that obligates all the physicians and actually all the health workers that have to be involved when the epidemics is established in a country.
Okay.
It wasn't.
Veerle, Katrien, how did that work in Belgium with all those individual these solid practices of GPs? Can one of you, were they also obliged to collaborate, or did they collaborate on a voluntary basis? How did it work?
I think I can't reflect on that specific part, I'm afraid, Diederik. So maybe if Katrien has a view on that, she can add. What in my experience made it very challenging is that our primary care system is quasi-completely fee-for-service paid. And because the normal patient flow stopped for primary care physicians for a big part, it was very, very challenging. It took some political decisions to make sure that the phone consultations would be paid by the GPs. So we had to install a lot of new regulations concerning payment for primary care physicians. And this was, in my experience, very challenging. We have a small part of community health centers working in another financing system. And this made it easier to be flexible in organizing because they already had a flow of money coming in. So this was easier, I think. And I think this was a challenge in Belgium.
And Veerle, was it possible, and in the community health centers, to combine, to integrate more the public health and the individual health of patients? Was that more easy for you in the community health centers than elsewhere?
In our experience, yes, but of course this is a context I know best. But we had, so in the community health centers we have general practitioners, we have nursing assistants, but we also have, for instance, someone working on health promotion. What a lot of the centers did was proactively look at the patient population. They have a designed population to look at at-risk patients, to proactively call them if they need some support. Some centers, they went to give personal protective material to the patients at home, or they supported with information for the children on what is COVID, so that parents could talk about the disease in an accessible way with their children. So they had a very big view on what the needs of the patients were. It was easier because they have a fixed patient population. Plus the staff that was working there, for instance, physiotherapists that couldn't work because of the challenge of infecting patients, they could be very flexible, reoriented to do some of this public health work. And I think this makes it much easier than in other organizational systems.
Yeah, okay. Katrien, do you have something to add on that from the Belgian perspective?
Yes.
You have to close the session, but please go ahead.
Yes, I worked in a triage center and they were all over Belgium. We have 60 regions where GPs were asked to make a triage center, and there was mostly in every region. There are some GPs that take the lead, and those GPs taking the lead, they then organize it and define which GPs has to come to take the tests, and they could not really, they are a little bit obliged, but most, so if they were older or pregnant, they didn't have to come because of the risks. And in all regions, this happened and this went smooth, but it only happened when the epidemic was already a week or two. It was differently from Slovenia. They did it before there was any patients. I don't think this would have worked to organize it before we could speak of an epidemic. Then you would not be able to get them to do that, I think.
Yeah, I think so too, and that's the beauty of having already that close collaboration on public health and individual health as it was presented in the Slovenian case. And I think that makes it strong in their reaction. We are all over time, but there is still a question of Anthony, and that's then really the last question. And then you might say a few last words, Thea, Tonka, and Spela. How is the experience of video consultation from the patient's point of view? Did they feel comfortable with all these online consultations? Maybe Tonka first. Spela?
Yeah, it depends. In this epidemic situation, patients realize that it is not clever to come to the doctors, and they use these telemetrics methods. And it can be that some diagnosis is done by use of these methods. But I think that patients, in fact, are not completely satisfied, and they are waiting for the situation which will enable in near future the indirect communication. I mean, coming in the office, talk to their patient and so on. But in this situation, it was not so difficult to diagnose, to let a diagnostic steps or process according to this use of these methods. And I can say this, mostly they were completed successfully. Maybe Spela, according to her work in nursing home or in retirement home, some additional sentences.
I think we organized the work in the retirement home quite successfully, because we prevented the spread through other healthy residents. I think we were quite successful because out of 380 people, only 17 tested positive. And only, I think a few, let's say 4 or 5 were actually asymptomatic, and we found them because we were very diligent when it came to testing. Every employee had to wear a mask. When you went to see a otherwise healthy resident, you had to wear gloves and a coat. If you treated people with COVID, you had full protective gear. So we were very diligent, and I think we were successful in preventing the spread.
We successfully solved out mostly problems with skin, which are seen on the surface of our body, and we also already suggested to the government to enable us to work with these simple things through different media and to pay these services like they were paid during this epidemic period.
Okay, Thea, do you have something to add on this question, the patient's point of view in video consultation?
I actually agree with Tonka. That the patients were satisfied during the epidemics, but of course not completely satisfied. They, especially elderly, they like to visit personally the physician. And now when we have not so many COVID positive patients in Slovenia, that we opened our practices, that patients would like to come, but we still try to do a very good telephone triage done by the physician, and to really decide what are these mild health problems that actually can be done by telemedicine, and what are the problems that have to be that needs to be the examination needs to be done, and that the people have to come to the clinics. So it's something that we saw that it's possible during the epidemic, something that before we didn't know, but now the people are more rational, because in Slovenia it's quite popular to visit a GP. We were quite crowded, and now it's a time that we use this epidemic also to organize our clinics, and we hope to succeed.
Okay, thank you, Thea. Thank you, Tonka. Thank you, Sprela, for this, I think, very interesting explanation what has happened the last 3 months in Slovenia, in Ljubljana. I'm going to close this session. I want to make you aware that we want to repeat this, in fact, and in a more even more attractive way, probably, during our scheduled conference in Ljubljana at the end of September, but which is now postponed to February. And I think we are planning now to have a virtual visit to the Ljubljana Health Centre, starting again maybe with the video, but at least to show what's going on in maybe the normal situation in September in the Ljubljana Health Centre. And then you can ask direct questions to the staff of the Ljubljana Health Centre. So let's keep an eye on our mailings, and keep the dates free on the 27th, 28th, and 29th of September. And we hope to see you all back by then. Bye-bye.